Hello members and welcome to a special recording from the Society of Sports Therapists. My name is Ashley Jones and I'm the Director responsible for communications on behalf of the SST. Following the recent changes to the government guidelines, the Society head office staff have been inundated with questions related to if and how members can continue in their sports therapy practice. Rather than answer each individual question or produce long-winded written documents, the board have decided to pose a series of these frequently asked questions to the chairman of the Society, Professor Graham Smith, to try and clarify the current situation for the members. So welcome, Graham, and thank you for agreeing to chat to me today.
Thanks, Ash. Good to see you.
So we're going to start with, I suppose, the most pertinent question that's come through, and then everything else will sort of organically grow from there. So first of all, we've had a lot of members asking, are they insured to treat patients in a face-to-face setting? So if you won't mind adding that one first.
That's a really good question, and you're right, it is a common question. You as a member are covered for medical malpractice and public liability. And that medical malpractice is to cover you for claims that may be brought against you for any harm that you do physically, physiologically, psychologically to a patient. So if we go back to November, for example, and if a claim was made against you or a complaint, then basically what you'd need to do is to justify why you did what you did and give the clinical reasoning behind it to basically support the actions. So that's what would happen. If you look at it now, the only difference is, or the only addition is that if something happened and a complaint or was brought in against you, then basically what you need to also justify is how you implemented or took into consideration guidelines that were in place at the time with regards to social distancing, PPE, hands-on. But the medical malpractice hasn't changed at all. It's the guidelines that surround it. So you're still going to be judged on your clinical reasoning for doing what you did. The guidelines that are in place by the governments are basically there, priority to save lives, secondly to keep people out of hospital, and third to reduce and minimize the transmission of what is really a deadly virus. So effectively those guidelines are different to the medical malpractice. So the answer to the question is, yes, you are insured, but you need to be able to know that you have to justify and give the reasoning for all that you do if a problem occurs.
Okay, well that's cleared up that one, so we can sort of assume that people need to be informed in what they can and can't do before they start. That's the main thing that we've got to take from this. So in terms of what measures would members need to be thinking about putting into place before they start with face-to-face treatments, face-to-face assessments with the current guidelines that came into force in the last couple of weeks?
Well, as you know, Ash, a great number of our members have been continuing to practice during the whole lockdown period. They've been providing really vital services to patients. They've been involved in a lot of the post-COVID rehabilitation. And so effectively, a lot of the members are already practicing and already have put these into place. And in a way, there are two parts to this question, two answers to it. The first is, if you're employed, then obviously it is your employer. It's their responsibility to make sure that they have everything in place that's going to basically to protect their staff and to protect the patients and the clients that come to see them. And so therefore, hopefully they've done the risk assessments, they've got health and safety, the PPPs in there, cleaning regimes are in. So everything has already been put into place. And the protocols are there for what happens when the patient comes. First question is it essential? Do they need to be seen face to face? That becomes an important part. When they come, the questionnaire, have they had their symptoms? Have they had symptoms in the past? And I think what's really been interesting over nearly the 4 months it's been going is we learn more, and we learn more even in the last couple of weeks about asymptomatic. So patients are asymptomatic. So effectively, you can ask a patient if they've had symptoms. That doesn't necessarily mean that they don't have the virus. So your employer has that responsibility to put all that into place. If you're self-employed and it's your practice in your clinic, then you have to do that. And you need to do a risk assessment. And you need to, again, that question, is it essential? What's going to happen when the person comes? Do they need to wear a mask? Effectively, the room that they're going to be in, is it ventilated? How long are you going to spend with them in that room? How is it going to be cleaned after? What PPE should you be wearing? How are things going to be washed? So there's a lot to do. And as you know, as a director, we've been looking at risk assessments, and we are at this. In this last few days, we were about to send a risk assessment details out to members, which we've had to change because the guidelines changed. So what we put together now is applicable to England, but we're going to have to modify it for Scotland, Northern Ireland, and Wales. So effectively, each of the 4 countries have their own guidelines for it, but it's the risk assessment. And do you need to see that person? And I suppose the other thing is the patient that's coming to see you aware of the risks that they face as well? Because effectively, you may be the person that has it and are asymptomatic at the moment. So it sounds quite complicated, but it's a case of putting into place correct protocols.
Yeah, I definitely agree. And I think you've touched on a really good point there, because you've mentioned about, do we need to see patients? And that brings me on to another kind of frequently asked question, which is around this virtual consultation, which is, hot off the press in terms of therapy in general. So I suppose in terms of insurance and in terms of liability, how do members stand about with virtual consultations? I know you've touched on it in newsletters and correspondence, but can you just put a bit more kind of phraseology behind it, explain a bit more about kind of how members are they insured, and how should they conduct these virtual consultations? How far can they go with regards to their diagnosis, etc.? Okay.
I think what's going to happen probably as we go through the questions, I'm going to sound a little bit like a broken record with some of the responses, and I apologise for that in one way, but as you know, sometimes it's to reinforce things. If I go back to the insurance, medical malpractice, that's covering you for the advice, the harm, what you do. And that's 24 hours a day, 7 days a week. So if you give an opinion which is based upon your knowledge and your experience, then you become accountable for whatever happens from that opinion. So, and sometimes I think, I won't say members, but all practitioners forget that they could be in a social situation, somebody asks them a question, they give an opinion, something goes wrong, and they come back, well, actually you said that was all right if I played football, so you're accountable. You said, well, I didn't assess it, but you gave that opinion. When it comes to the virtual, it's exactly the same. Yes, you are covered, and you are insured for it, but the same applies. Now, as you know, from the very early part of the lockdown, we advised members, to basically continue to see as many patients as they could virtually, to basically continue with the advice, continue with the exercise, monitor the patients, and virtual practice is now probably increasingly more acceptable, and it's something that you'll see more and more within that health, in basically traditional healthcare. Clinics within NHS hospitals now, wherever possible, are being done virtually, and patients are only going for when there is no alternative to it. And again, I think it's with ourselves, our members have been able to continue with a lot of their practice and a lot of their relationships with the patients virtually, because they can continue. But those are the patients that they know. Mm. And I know that the next question you're probably going to ask is, so what about new patients? If you're approached by a patient you've not seen before, who has a problem and wants to see you, and you're doing virtual, you can only give generic advice. You can only eliminate sort of red flags. You can listen to their symptoms. You can't give a definitive diagnosis or hypothesis, because you're not going to be in a position to see them and to basically do necessary clinical tests which would help you to determine the detailed treatment. But there's a lot of advice that you can give to patients. back patients can be given a lot of generic advice to help them once you've gone through the standard questions to eliminate the red flags. So again, it's down, you are accountable for what you do. You have to be able to justify it and clinically reason. And I think as you know from the background, from where you work, even in education, so much is going to be done virtually. And this is going to be part of the new practice. And it's part of practice. You're giving advice, you're just not giving it in a room at the same time, but it's still the advice that you would give that patient if you were seeing them face to face.
Yeah, I think that clarifies things, because I think, what members have got to understand and clinicians have got to understand is that if you can't lay your hands on somebody, your level of understanding of their signs and symptoms and their clinical impression is very different. And I think that's where people just need to understand that if it's an essential face-to-face meeting in order to make definitive diagnoses, and the risks are accepted by the clinician, the therapist, and the patient themselves, and then that's when a face-to-face consultations possibly can take place. So we're going to move on to I suppose, how these physical interactions are going to take place now, Graham, a little bit. So talking about the level of risk and how to negate that risk. We can't remove it, but we can try and reduce it as much as possible when we see these people. So in terms of when we get a patient to come and see us, can we sort of conduct, or can a therapist conduct a physical assessment within the social distance regulations if they are PPE'd up to the level that they should be?
The reason for the recommendations on social distancing is because what you know and what science is beginning to confirm is that if you are outside, or if you're over 2 meters away from an individual, then the likelihood of transmission is reduced and minimized. It's not negated, it's minimized. The closer you get to that person, then the greater the risk of transmission. And the longer that you spend in close proximity, then effectively, the more that increases. So if you and I are in a room and you're my patient and you've come to see me, there is so much that I can do with you, maintaining the social distance. When it comes to the physical part, where I may need to palpate to determine, is it your glenohumeral joint, shoulder joint, or is it the acromion process, then it may be necessary for me to come close to you to palpate. The moment I come within that distance, I increase the risk of transmission both ways. PPE is there to protect both parties, but it doesn't negate there is still going to be a risk as well. If I fleetingly palpate and move back, then the chances are reduced quite dramatically. The longer I spend in close proximity to you, the greater the risk. But the patient also, so you as the patient also have to be aware, and you've also have to agree that you are going to allow. So actually, if it is necessary for me during this assessment to come in and palpate your shoulder, are you happy with that? So I would need to make sure that we have your permission, and that has been signed off as well. So the social distancing and the guidelines are just that. They are guidelines that have been determined to minimize and try to eradicate the risk of transmission of the virus. So, can you conduct a physical within it? Why would you want to do it? How much time do you need to do it? And basically, are both parties aware of the risk for it? So I know some members have contacted, what do you mean by, and the question, what do you mean by urgent and essential? Well, is it necessary for me to palpate to determine whether it is your glenohumeral joint or your coracoid process? Is it necessary? Is it urgent? So if I can justify that in my opinion it is, then I would do it. But you've got to be able to say, yes, I needed to do that. So, I think if it was to determine, is that a bony pain or is it a soft tissue pain? So in other words, could it be something that really needs urgent referral on? It may be necessary for me to breach those social distances. So in a way, the long answer, and I'm sure a few people, well, you've not really answered it, but so much of it comes down to the clinician and the practitioner's own cognizance to do it, the patient's under agreement to it. And it's really, I think, and you've heard this in conversations many times, this is about saving lives. This virus is unlikely to be eradicated in the short term. So effectively, we're going to have to modify a lot of the things that we do, because we're not going to be waking up on August the 1st and it's gone. I think when you look at it overall and and you put it into context, it's going to be very much like SARS and HIV and swine flu and a lot of the other flus. We may develop a vaccine that will help to control it, but it's going to be there. And we may be having to now modify the way we do things for a very long time. And it's about protecting the practitioner and protecting the patient, because if I am asymptomatic and I come into close proximity and I do basically infect you, and you leave not knowing that, the chances are that you're now going to mix with anything from 8 to 10 people that now are going to end up having the virus as well. So why do I need to be that close? Is it urgent? Is it essential? Can I justify it?
Yeah, I think the two things that you take from that is the justification for that, breaching those distancing guidelines, so the essential nature of it or not, and also the consent. So making sure that the patient is fully aware of the risks of you doing that. And if they're sort of happy with that and you're happy with that, and you can show that there was a justified requirement for you to do that, then things are more positive than previously.
Just sort of, sorry to interrupt you, to add on to that. One of the things what we often get is about other practitioner groups that, oh, they're doing this and they're doing that, and effectively, I think we've worked very closely with the other organisations that's similar to ourselves, and we all think along the same lines with regards to this. And the recommendation is virtual wherever possible. The recommendations are it's got to be urgent and essential, and effectively, when you're looking at this close proximity stuff, and that's in a way one of the key things, one of the key issues that came up on July the 4th, about so many people were really looking forward to to massage parlours, to nails, to beauty therapies, and all those being open, but they are close proximity businesses. And it's about, the reason they're non-essential, close proximity. And that comes into it. The longer you spend in close proximity doing something that is non-essential, the greater the risk of transmission. And that transmission then means that you're going to need more people going into hospital. And, I think when you see the consequences of this condition and what it does to people, and we know, you hear the dramatic side of things, but people who have had it and recovered, it's very debilitating. And what we're going to do is we have to minimize that. And we as practitioners can do a lot to help people, but we've also got to make sure that what we do is in providing that help, don't make it worse by being part of the picture that increases the transmission. Yeah,
and I think we were having a brief chat before we started this, and you did state that other member organisations are having similar queries and questions to yourself. So it's not something that our members should feel that they don't understand and that others do, because these sort of queries and questions are coming from everybody, because this is something we've not faced before as a nation, and there are differences within the devolved nations as well. So that makes things quite challenging at times. So I think the main...
And as you know,
Mm.
it's confusing because what happens is, all of a sudden announcements are made and then we don't know, and the guidelines are changed. Yes, you can do this. No, you can't do that. And then up till probably the first 8 weeks, it was easy because all 4 countries were very close together.
Yeah.
Where it's now become quite interesting is that, what happens in England is different to what happens in Scotland and what happens in Northern Ireland. So at this time now, as we're doing this interview in Wales, if you're a massage therapist, you can work.
Yeah.
In Northern Ireland, if you're a massage therapist and a tattooist, you can work. If you're in England, then you can't work. Yeah. They don't want you to open your business. In Scotland, it's the same as it is in England. So you have all of these things going on at the same time, and it gets confusing. And you can understand why members suddenly think, "Oh my God, what does that mean to me?" And we've tried wherever possible, to get a lot of information out to try and make it as clear as possible, and without saying, "No, you can't," because you are an autonomous practitioner, and you are accountable for your actions.
Yeah, I think hopefully this video will at least clarify some of those points and make people feel a little bit less alone in their thoughts as well. So we talked about kind of if we do have to breach these social distancing guidelines to perform a physical assessment to treat somebody, we think it's an essential requirement that the patient's happy. What level of PPE do we sort of need to wear? That's something that's been coming up regularly.
Well, obviously, you should be wearing PPE. If you're seeing any patients now, you should be wearing PPE. And if you look at the minimum should be gloves, face covering, apron, and ideally, if you are going to be getting into close proximity, then really you should be wearing either goggles or a face visor as well. Yeah,
and sort of if that's adhered to and members are wearing that level of PPE, and they're happy with the risks, and so is the patient, then what we're saying is that they would be able to lay their hands on for a period of time.
It comes back to that good question, that period of time. Why would you want to lay your hands on, and is it necessary, and can you justify it? Is it urgent, and is it essential? So, so effectively, if you have that PPE and you're doing a clinical examination and assessment, and you need to determine something because that's going to make a major influence on your decision as to whether that person can be given exercise and advice or they need a referral, then you would do it. But if it's just a case of, well, I think I'll go there because I just want to do some gentle soft tissue work, well, that soft tissue work, the length of time that you're doing it, that curve starts to increase of the risk. And then, is it necessary? Yeah. Is it necessary? Is it urgent? Is it essential? Are there alternatives that you can be doing to it?
Yeah, I was going to say, a common question has been around the soft tissue work, sports massage, mobilizations, electrotherapy, things that require you to go into that very close proximity for a lengthened period of time, because it's not just a single clinical test; it's a treatment that can take up to half an hour.
Yes.
So what would you sort of say to that, and what have you said to members when they've asked those questions at the minute?
Avoid it.
Okay.
Avoid it. Yeah, and that sounds, that's a bit harsh, because that's what I do. That's what the member or the clinician will say. But I need to do that. Well, do you need to do that? And our responsibility as a professional body is to our members, and it's also to our members' welfare. And a lot of the advice and the guidelines that we've given, we try not to be the big brother. So in the early days, we basically said, be cautious on what you do. Think of your insurance. Are you going to be covered on the insurance? It's a bit like the travel. The guidelines that are, you shouldn't travel overseas if it's non-essential. That doesn't mean don't do it, but if you do, then you have to, and something goes wrong, you need to be able to justify the implications for it. So I think when we look at the close proximity stuff, it's always, is it, that sounds all, as I said, the broken record bit, is it urgent? Is it essential? The patient wants to have a massage because it makes them feel good. That's not urgent, that's not essential. And there's a risk. So therefore, minimize the risk. Minimize the risk of that transmission. So what we're trying to do is, basically is to protect our members and the people that they see. It all sounds, God, he's a bit dramatic. This is about saving lives, guys. This is about keeping people out of hospital. We're doing this interview on the day that they've just announced on the news that Melbourne is going back into a lockdown for 6 weeks. Australia has done well. They've really done well with low death count, but all of a sudden, because of things being opened and people's interactions, there's an increase in the cases. And now the city is in a lockdown for 6 weeks. They've closed the border between two of the states. That's the implications of what happens if you spend too much time in close proximity with people.
Yeah, and I think from my point of view is that if I put my sort of clinician hat on now as well, sports massage, mobilisations, electrotherapy, they are tools within our expansive toolkit as a therapist. So we might have to just modify the way that we would treat a patient in order to maintain our safety and theirs. Doesn't mean we can't treat them. We just need to be a bit more maybe creative or a little bit more alternative to what we've traditionally done, which is actually could form a really positive experience that could take us forward. But we've just got to think about the implications of whatever we do.
Yeah, I agree 100%. And just sort of one thing that sort of comes to my mind is, just going back to the PPE, actually, is, don't wear the same PPE all day. So, if I'm wearing gloves, apron, and a face covering, and I see you, and then you leave the room, I need to change my PPE. And I need to make sure that the deep cleansing has got this. So it's not a case of, I'm going to put this face visor on, I'm going to keep it all the time. This is my face visor for the day. No, it's not. This is my face visor for this interaction between me and myself and you. So, and I think sometimes, have you got adequate PPE? So you're not going to get dressed and put everything on and keep it on for the rest of the day. Everything needs to be changed after every interaction. Yeah,
and also I suppose that goes for the end of the day as well, in terms of making sure that you're not taking it home to family and friends or people that you cohabit with. So, have you seen any advice about how to sort of manage your sort of personal hygiene in that way?
That's it's a really good point, and it's one of those things that often gets overlooked. I mean, ideally, you should get changed before you go home. So whatever you're wearing in that clinical situation, you should get changed. So, and then what you take home with you, basically, if you've been seeing patients and you've not really been in much close proximity, when you get home, that stuff should go into the washing machine, basically be washed. If you've been seeing a lot of people and during the day you have spent time in close proximity, then you make sure that you put it into the washing machine with nobody else in that room when you do it. You then wash it at the hottest wash possible. So effectively, I live with somebody who on a day-to-day basis is coming back from hospital and being on clinics, and I leave the kitchen whilst she puts the stuff into the washing machine, to make sure that it goes in and it's there and it's clean. Because the other thing, of course, is that your clothes and your uniforms are not going to be washed with everybody else's, and you can see that with the football. I mean, when did you ever hear about Premier League footballers having to take their own kit home and getting it washed? That's the bottom line at the moment. The clinic stuff itself, obviously, you don't really want to be having pillowcases and plinth covers, so your plinths need to be cleaned, scrubbed down after every patient, and effectively any papers that are there put into the correct bags, so that so that effectively, again, you are minimizing the risk of this virus laying around and being infected. So, but you did raise a good point, and don't just finish the clinic, go home. Think about what you're taking out and who you've seen during the course of the day.
Yeah, definitely. I think that's a really good point, because again, it's sometimes when you've got the work head on, and then the work, you finish at 5 o'clock, you've got to think about actually your work's not done until you are as sort of cleansed as possible before you start interacting with others.
It's actually going to be it's actually going to be a challenge that you guys are going to have in the universities as well, because effectively when the students are coming back, and I know in a lot of the universities that the society sort of collaborates with, that the students get uniforms and kit. Well, how many does that have to be increased now, so that that they are changing much more? I mean, there's a whole the phrase goes, there's a whole new world out there, and we are going to have to adapt. So not just on the clinically, but the next generation of our members and our clinicians are going to have to be taught, because this is probably what they're going to have to deal with for a long time when they qualify and when they first start to practice.
Yeah, definitely. I think there's a lot for us in education to consider over the summer and to get in place before we welcome the students back. So, final question really is around the students actually, and it was a question that was brought by several members who were helpfully provide placements for our students in their private clinics or in their sporting environments that they work within. So what's the current guidance and recommendations about taking students in with regards to placement experience? Because that's going to be something that will obviously heat up once the students arrive back to universities in sort of September, October.
I think it's just almost like sounds like the old cop out answer and knocking it back into the court in saying that a lot of that will be between each of the universities and their clinical placement providers. I think just to briefly expand on it, I think the clinical placement providers are going to have to put into place and get confident with their own protocols and their own working practices before they start to take students back. But I think that so once they're comfortable, and as you know, there is a time now over the summer and leading into sort of what will probably be a delayed start. And I don't mean a big delayed start, but by the time we get to October and people coming back into it, that at that point in time, for those the senior, of the final year students that would normally do placements over the summer, and a lot of them will go into the clubs. I think that this summer there probably won't be as many placement opportunities, because, as you know, clubs are having to come to terms with their new working practices. So, effectively what you see with regards to sort of what's going on with the Premier League, they're not going into posh dressing rooms. They're not got all the treatment facilities that they had. They're having to get changed in porta cabins, and they're having to sort of, their rehab equipments now is basically. So I think, again, the clubs are going to have to adapt to the new practices. So I think there's going to have to be a lot of discussions between the universities and the placement providers. However, within the universities themselves, I think there's a great role now, because the virtual clinics and the virtual consultations are going to become an important part. So I think that's an area where that, and if you take students and you're doing virtual clinics, that's supervised practice. So it's an alternative way of providing something they may not be able to get in the long term or in the short term. So I know that sounds like a quite long, complicated answer, but hopefully sort of puts it into context.
No, I think it's very clear. The society oversee courses. We don't micromanage them. There has to be a level of responsibility from each university as to how they want to do things and how they see fit. And I think, again, it will very much depend on the placement providers that they select and use as to what they have in place. I think there's obviously just more levels of responsibility that fall at the university's feet, but it's useful to know that the society, as always, will support and help in any way they can, but without taking the absolute decisions, because the universities have to do that for their best interests. So, I think it is a watch this space very much in that arena, really, because there's so much uncertainty, and so much could change in the next 3 months as well before the students really would do that. So, so that was the list of questions, Graham, that came through. So, have you got any kind of final closing remarks before we kind of finish the podcast for the recording?
I've actually got one question which sort of came up yesterday, and it was one of those, and this was a question that we had and another of the organisations had from their members as well, which is basically, do I need to wear gloves or can I just wash my hands? And which, when you hear the question, it sort of makes us go, wow, hang on a second. And you often hear, well, if I'm actually touching the patient and I've got gloves off, I don't get the same kind of feeling. And then this virus transmits through bodily fluids. So effectively, what you need to make sure is that wear gloves at all times, and then when you've finished, take those gloves off and wash your hands thoroughly. So the answer to the question, should I wear gloves or wash my hands, is yes, both.
Yeah.
The washing of the hands is important, but it is the gloves that are going to protect the surface of your skin and the surface of your patient's skin. So wear gloves at all times, change those gloves, and the moment those gloves go off, wash your hands.
Yeah, I mean,
go on.
No, I was going to say the minimum PPE requirement that you mentioned earlier was included the gloves. So yeah, I think it's something that members should be very switched on to now. It's protecting yourself, and it's single use is the key thing as well. It's not using the same pair on several people to protect yourself, because you're passing it around potentially various different people. So yeah.
I think the only thing, closing remarks, I suppose I'd say, is that obviously these are challenging times. People do it at the unprecedented times, and as an organisation, professional body, we've tried to do everything we can to help and protect the members and advise the members. And that on the website, if you go on under COVID-19 sort of guideline, we've given a lot of information out there. Sometimes, when there's an announcement comes back, and to get an email like half an hour after the announcement, so what do we do? We do need sometimes to take a little bit of time, and we will respond as quickly as we can, but we've got to make sure that the advice and the information that we get out is correct. And probably what I would say is that if we do send the stuff out, and I know when it comes it's text, you have to read it, please read the text and have a look at it, because sometimes we get questions back and we've already given that answer and we've already told that information. So we will get information out as quickly as we can and as much advice as we can. We're not here to stop you working. We're not trying to stop you. We're trying to give you the best advice, one, so that you can work safely and effectively, and you're protecting yourself and you're protecting the people that you see. That is our priority. And our staff and Claire, my secretaries, worked really phenomenal job over this past 12 weeks, and we try to get as much information out and response to members as we can. But sometimes just have a little bit of patience, and remember, we're having to try and correlate a lot of information that's coming in that relates to all the countries that our members work in. So it's not just for one country, but it's been great to have the opportunity to chat to you, and I really hope that what we've been able to do is clarify a few things, and it's much easier than having to read a whole lot or even write it. So yeah, thanks Ash, it's been good to talk.
No problem. I mean, I think closing remarks from me just as a director as well is that Graham's absolutely right, that with the membership we receive the information at the same time as you do, and we need to take time to process that and formulate the correct and well-balanced response. And I'm sure that every member would much rather us take a little bit of time to ensure that what we're telling you is correct, and has been well thought out rather than being reactive. So, you know, hopefully this video, coupled with the newsletters and all the other information on the website and our social media channels, there is things on there as well from the last few weeks, will all help you to I suppose know what you can and can't do at the minute, and the decisions that you've got to make as a clinician independently. But as always, the Society are here to support you. So please do get in touch with us if you do have something that we haven't covered, or something that you think you either don't understand or want some further clarification on. But hopefully this has gone some way to addressing various people's thoughts. So thank you very much, everybody, and stay safe, and we will hopefully see you soon. Thank you very much.
Thanks, guys.